Good morning. Welcome to Oldies but Goodies, the Geriatric Patient. I'm Daniel Schring, you guys' medical director. This is the Friday morning lecture series. Hope everyone's doing well. So, by definition, geriatric over 65. Mark, you're getting there soon.
21 years.
Yep, 21 years. Of course, with everything else that we do with it, and we're going from the perspective of dealing with the patients, all that stuff, it's the unique challenge that they have for us. And of course, unique challenge here because how much of our population that comes to the casino is?
Well, it depends on the shift. All of them on day shifts.
Okay. So looking at kind of sort of we're going to go down societal issues, medication uses, talk about the senses that they have, a little bit of the body systems, and then the trauma and elder abuse and all that stuff. So in regards to societal issues, what are some concerns or topics and stuff like that? What do they have, don't have? Dealer.
Might not have anybody around, any family.
Okay, so loss of support system.
Not working anymore, they might be retired.
Retirement.
There's sensory delays.
Sensory losses that we're going to talk about in the two. Okay. Medications. How many medications do these individuals have? Okay. Actually, I have a couple pictures in the future and all that stuff to show. So, yeah, medication is always a huge thing. And then, as we talk about body systems. And with this Pokemon Go, I think this is pretty much a common thing right now.
Ooh, the oldest of the two with that one right now.
Yeah, exactly. Our elderly patients are doing the Pokemon Go. So if you think about it from the perspective, 20% of the population by 2030 is what they're estimating, will be quote unquote geriatric. A lot of it's from the baby boomers. And just now, I mean, if we look at societal wise, young individuals were not, families right now aren't having the huge families that they had, 30, 40 years ago. So it's really that perspective of going on. And numbers wise, okay, 22 to 39% of our call volume is based upon a very small age group. They say it's 15% of the population counts for about half of our EMS volume that we see. So, and we could probably all shake our heads going, yeah, it's probably true and all that stuff. And of course, it gets worse as we get over the age of 85. So the super geriatric, or I think it's the advanced geriatric, or there's another term for over 85 if you make that time period. Number-wise again, for the geriatric, 12.5% of the population again, but they count for 1/3 of our traumatic deaths. So just giving us numbers and statistics and all that stuff. So it's a huge, but really if we think about it, how much education do we do on the geriatric patients? Probably not as much as we should, but we see a lot of all that stuff. So with societal issues. All right. Blank there. Okay. Living alone, of course, we talked about that. They lose their support systems, they lose their spouse. Okay. And usually once the spouse dies, if it's a geriatric patient, how long before that individual dies? Up to 6 months. They say within a year. Yep, 6 months to a year. Yep, within a year they'll have that. And a lot of it is just, especially if you've lived with that person for 50, 60 years, and you give up. Systems shut down and all that stuff. Loneliness, support systems, and stuff like that. And then the loss of independence. I turned 40 and I started wearing glasses. I don't know what's going to happen when I turn 60. From that aspect.
Ask Mark. I'm not the one wearing glasses.
And then all the untreated illnesses, how many individuals they quit taking their medications, they're tired of taking the umpteen thousand meds and all that stuff, or they choose not to go to the doctor, or they don't have doctors, and all that stuff. We do know that, compared to the 1700s, what was the average age of death at that time period? 40, if we're lucky. I mean, now we're just, we got individuals 100, 110. So just living longer and all that stuff. We're not Moses or anything like that, living 700 years. We do know that the ones that do get into groups and socialize, getting out and all that stuff, they do a lot better. Hence the picture and having fun and all that stuff. Positive aspects. Stimulations and all that stuff. Okay, so the question is, and we always have on the next page is, in regards to DNRs, how far, should we actually go to take care of the over 65, over 85? They say that the last 15% or the 15% of the population is, half of the ER visits and half of the money dollars and all that stuff spent. So can we go there and all that stuff? Right. Questions on DNRs? Anything?
Where do you draw the line in comfort care?
Yep. So if you look at the right-hand side in regards to what we will do and what we will not do, the comfort care is exactly that. Starting an IV, giving some IV fluids, is that comfort care?
Some look at it, some don't. Some say it's invasive.
Correct. Putting a patient on CPAP, is it comfort care? It can be.
Depends on the situation where you put it up.
Yeah. Let's say someone, they're in fulminant CHF, they're short of breath, and they're gasping for air and all that stuff. So yes, the unfortunate, even to this day and age, there's still fine lines even with the DNR stuff. When in doubt, that's what I'm here for, to ask questions and all that stuff. Question was brought up the other day in regards to DNRs is, can a power of attorney revoke a DNR? In the medical power of attorney. And the Ohio law actually says no. Okay? So if the person was in sound mind, body, and all that stuff, they went to the doctor and they initiated the DNR, that directive supersedes everything. That's Ohio law. All right. Now, of course, the difference between the arrest and just the comfort care and going from there.
Okay. With that being said, they go in, they get the DNR, and it's signed by a PA.
That is
Avoid. A PA can't sign a DNR.
They can now.
At the time they couldn't. Okay.
Yeah. PAs and NPs, nurse practitioners and all that stuff can sign that stuff now.
You originally wasn't.
Yep. The law just changed about 6 months ago. And that's the same thing like with med control. PAs and NPs used to not be able to be med control for EMS. They can now.
So say you got somebody in full arrest and their medical power attorney's there and doesn't disclose the DNR, does that fall on them then at that point?
Well, yeah. We have to assume if there's no DNR that the person's a full code. And we would work the rest like we would and all that stuff. Now, that's an ethical issue on their part.
But that would fall on that, not.
Correct. Yep.
I love the one. They're a DNR. Get paperwork? No.
Of course.
Not to me.
Yeah. My take is always, if you got 15 family members there and all 15 family members are saying they're a DNR, where's the paperwork? We don't have the paperwork.
Careful. I'm working you.
Well, yes, no.
I can't take somebody's name I don't know from a hole in the ground.
But if you have 15 family
I don't
members,
know their family members. I just walk in somebody's house. I don't know who your family is.
true. Usually if you have 15 people around and all that stuff and they're all
They could just had a
different
party.
ages. Yeah, whatever.
DNO party.
We're going to kill this one off.
Get rid of her.
Okay. As we continuing on, and it's just the facts. Okay. Sitting down and you can probably get your earful on the ambulance ride from a mile up the road, and you have the whole history and all that stuff.
You took your own medicine cabinet.
No, that's not quite my medicine cabinet. Thank you very much. I have more.
He's got the baby stuff.
Oh, I forgot.
All right. So dealing with the senses. As we get older, we lose our visual acuity. We lose our ability to look at colors. We develop cataracts and glaucoma, the pressure in the eye and all that stuff. And of course with the cataracts, the aspect of needing lens implants and going from there. They usually say about the age of 40, you start having problems with your vision and going down. Even this day and age, it's even worse because with vision loss. Technology and all that stuff. Everyone's looking at their cell phones, their iPhones, they're reading in the middle of the night like my wife does. Laptop computers and going from there. So cataracts, basically, it's just the hardening of the lens. You have the ability for the lens to accommodate or adjust for your near vision and far vision. They can have problems, other things with double vision spots and ghost images. You just can't see properly. And Medicare, Medicaid, and all that stuff will pay for surgeries for the cataract surgery and going from there. So if you look at the eye itself, some individuals you can actually look at and they have the little bit of white on the front of their eye and all that. That's what that cataract is. Or shining lights and all that stuff. So the different layers of the parts of the eye, of course you have the anterior chamber, the posterior chamber. The lens splits it in half, or actually it's more of 1/4 and 3/4. And then you can have fluid and all that stuff. Now when we go to glaucoma, what's called the vitreous body, that area there, that's where all the aqueous humor or the fluid in the eye is produced, and it goes into the front part of the anterior chamber. You get a lot of pressure, get a lot of fluid in the vitreous, goes into the anterior chamber, and that's what causes the glaucoma, that side of it. So just increase in the intraocular pressure, potential damage to the optic nerve. Once we damage the optic nerve, then we have problems seeing and all that stuff. So hearing loss. Okay, what's tinnitus? Okay. Anyone ever heard of Meniere's disease? What?
I've heard of it.
Okay. Meniere's is a triad, not a common, but it's there. They have hearing loss with some tinnitus, and then they get the room spinning sensation, so the vertigo and all that stuff. That's the Meniere's. And then, of course, by the age 65, 70, 70% of all individuals have hearing loss. Even worse, especially depending on what type of work that we did. Did we actually wear hearing muffs and all that stuff? Some of us that have to wear the headpieces and all that stuff, direct, people screaming in your ear all the time. Of course, that does a lot of problems. Going from that, the rock bands that we listened to in the 20s affect us in our 50s.
Oh.
I was like,
I was like,
1920s?
what?
Rock bands when we're in our 20s.
No, you said in the 20s.
Oh, the 20s. In our 20s.
Glenn Miller.
I thought I was the only one.
Little AC/DC.
I only want the ACDC was around the 1920s.
I don't know, there might have been. Have you seen the members of
That's
it?
true.
That's why they're all quitting.
Smelling, touch, they lose feeling, they lose sensation. What else? What's another reason that they lose sensation? What do a lot of these individuals have? Diabetes. Okay. They got the diabetes, they got the sugar problems. Okay. We lose smell. When we lose smell, we lose our taste. Okay. Because remember, there's only four. Actually, our taste is only four things. everything else, that all the aromas and everything else that we actually is actually smells that we get. So as we go older and all that stuff. Problems talking or hearing and all that stuff. Okay. So in regards to the actual talking to the patients, okay, sometimes you have to get straight in front of them, looking at them, can't be to the side because they can't hear you, especially if they're in a cervical collar, if they are a trauma, standing over top of them or looking or something like that, if they're on their backboards or on the beds and all that stuff. If you can, trying to sit them up and doing all that stuff. Do we, at times, yes, we might need to talk a little bit louder, might need to talk a little bit slower. But don't assume just because they're older and all that stuff. Did that to a patient a couple weeks ago. She's like going, honey, I can talk just fine. Thank you very much. I was like, yes, ma'am. Next patient I went to, he is like going, screaming out the door. Try to get or stop family members, okay, from talking. That's actually one of the things that annoys the bejeebers out of me. When family will start talking for them. This is what's going on. Let them talk. You know, again, that goes back to part of the independence. They want their own independence and going from there. What's the I don't want to bother anyone syndrome?
Basically, I don't want to be a burden with anybody. They're so used to being independent, they don't want anybody else to have to worry about.
Okay. What else? Kind of sort of label it out there and all that stuff. Okay. They trivialize. They might be having an active heart attack. Well, I'm fine.
Just heartburn, don't worry.
Exactly.
I had it the other day.
It'll go away.
I'm okay.
Yeah.
It'll clear up in the morning.
I'll rub some dirt in
You
it.
don't like that.
Yeah. 20% of individuals that come in over the age of 65 with abdominal pain will die within a year, mortality-wise, just for undifferentiated abdominal pain. And they say, I'm fine, no, I'm fine. Okay? Speak slowly, avoid again the acronyms, medical legalese that we do a lot of times. And go from there. All right. So how do we actually assess them? All right? What's the difference between physiologic age versus chronologic age?
Actual age and how.
65 and have 95-year-olds.
Okay. 65, 95. How many of the 35-year-olds that we see that go, God, you look
Yeah, rough.
rough? Yeah. They look 70, 80.
Looking at me.
The guy we passed around today was only 47. Yeah. that was-
The what?
Serious?
Yeah.
What?
He was like,
Does
he was like in
pictures-
his 60s.
So that dude.
I know.
It's like, wow.
Yeah. So some people, they've had very hard lives and all that stuff. Of course, smoking, alcohol, other things.
It's something.
Wow.
That was,
In regards to assessment wise, okay, a lot of times they'll delay treatment, they trivialize the symptoms and all that stuff, and then they just, everyone thinks that, they're just getting old and all that's the problem and going from there. Okay. Organs of age do not cry out. Okay, again, this goes to that whole notion of with the diabetes, they lose the nerves that we talk about into the nervous system when we get down to that a little bit. That's the whole sensation piece. They just don't know what's going on. Pathology-wise, 85% has at least one chronic disease. Okay, 30 with more than one. Okay, a lot of the symptoms mask problems. Okay, or what else masks some of the disease problems? What? Treatments such as what? Specifically, which drugs?
The good kind.
Yes, heroin and all that stuff will mask symptoms. Okay. The majority, let's say 85% of our patients or 85% of our customers here at the casino, what medication are they on?
Probably pain meds of some sort for
Heart
arthritis and
meds or
whatnot, so it's masking, hey, I'm abdominal pain because it's being messed with it.
Okay. What else? Heart med. What heart med? Aspirin. Nitro. What else? What other high blood pressure medication? Not so much less than the but yeah. Metoprolol. Okay. What's metoprolol? What type of medication is that? It's a beta blocker. Yep. All right. So again, these individuals, so they have heart disease, and what other disease do a lot of them have? Obese. They're obese. Kidney disease, usually related to high blood pressure and diabetes. Okay. So with diabetes, okay, so sugar drops, they become hypoglycemic. What happens to our body? What's our body response to low blood sugar? What's our signs and symptoms when we get low blood sugar? Dizzy. What? Diaphoretic. Weak. Lethargic. Tachycardic. Pass out. Okay.
Been there.
Potential seizures and all that stuff. Okay.
Did that in Corndice.
So from that aspect, being on metoprolol, though, metoprolol can mask the symptoms of diabetes, okay, or the low blood sugar. That's all sympathetic response. Take that in consideration and things like that. Okay. Alter presentations, they might not have the pain. They have the aspect of the thirst mechanism might not be working properly. That's why you have a lot of individuals in the elderly in Chicago during the heat waves. Okay. They just don't realize that they're thirsty and all that stuff. The confusion, hallucinations, which again, a lot of it depends upon illnesses and infections. Okay. And going from there. Communications, of course, from the aspect of hearing, they have problems seeing, mental facilities, they don't think properly, they can't, oh, well, yeah, I remember that, and then going from there. Depression does play a huge factor, pulling out and going from there.
What the hell is he wearing?
I was thinking about that.
I think it's Punisher.
Yeah.
2 guns.
Okay. Again, from the aspect of history taken, trivializing, they making, everything's non-specific. They might, I have problems with this, and and by the way, this. So they'll come with a whole bunch of different complaints and all that stuff. And for us, it's a matter of, shifting through the weeds to actually find the actual problem and all that stuff. And then patients, a lot of times, they just don't want to tell you what's going on. Or they can't tell you what's going on, and then we have to become, it's veterinary medicine. Again, from the aspect of talking to the patient first, if you can, I like trying to do that, being respectful to them. And then sometimes you might have to get the family because, to elicit a little bit more of the history taken, all that stuff. Again, the near middle field vision, don't assume deafness and start shouting, okay? Walk in, just nice voice first, speak slowly, all that stuff. And if they look at you and go, huh?
Then you know.
Then you can start increasing the tone of your voice and all that stuff. Okay. Do not assume confused or disoriented patient is just senile. All right. Huge. This is probably the most important thing. All right. So someone that is acutely confused, what's the problem? And if they're geriatric.
Yeah, that's a big one.
Okay. UTI until proven otherwise. Some form of infection. And how do we take care of the UTI?
And do you?
Okay.
We don't.
I ain't going down
Yeah.
Not again.
Medications, this is, down on the bottom right. I mean, that's some of the patients that I have. Traditionally, they say they should have no more than one medication per decade of life. That's the ideal thing. That's what you're allowed. Yeah. You have heart disease, you got 5 meds right there. Bam, have a good day. So getting history, sometimes you have to look at the actual medications. Sometimes it's a matter of talking to, the family and all that stuff. Make sure that you ask about over-the-counter medications, okay, vitamins, supplements, and all that stuff, because a lot of the times they won't think about those meds, and they do have a factor in play in all that stuff. And then once we get the mobile integrated healthcare working, from the aspect of treating the patients in the homes, and the crew members will be actually contacting the doctors directly and all that stuff. So we'll be in the future being a bridge between the hospitals and all that. Assessment, again, asking is this an acute or chronic problem, and going from there. Okay. Acute problem, what do we want to do? What's our initial assessment and all that stuff?
Second one's for you, Brady.
How do we begin our assessment? What do we start with? Bueller.
PSI seems safe.
PSI seems safe. Okay. Woo! We got somewhere.
Introduce yourself.
Introduce yourself. Evaluate surroundings.
And ask what you're here for.
Okay. So asking what you're here for. If the person answers, why is that such a good question?
Because your dispatcher sends you on one thing and they're complaining of something else.
Okay. And what else? What does that one question do for you? Okay. They're awake. Okay. And the breathing, they have a pulse. Okay. And then, of course, doing your sample history and going from there. On the exam, okay, of course, having the person sitting up, they can fatigue easily if they're short of breath, and going from there, try to get them in a nice, position of comfort. Consider modesty. Trying to do an EKG upstairs. How often do we see that? Okay, the crew members and all that stuff. Pull them out of the room, pull them down here to the team member entrance, and go. Yes, I know.
Depends on the crew.
Yeah.
How new they are.
Uh-huh. Most of the time, if the patient, if they say it hurt, it really hurts. I have some individuals that come into the emergency room quite frequently, even in their over 65. Okay. They are our loyal customers. And going from there. Okay. So misleading stuff. So from the aspect of skin turgor, we can't really tell if they're dehydration. Okay. A lot of the individuals, especially if they're chronic bedridden, a lot of them don't properly breathe through their nose and all that stuff, so their mouth could be a little bit dry. Again, from the aspect of if they're chronic bedridden or they don't get around and ambulate a lot, from the aspect of having the rows and the crackles in the bottom of their lungs. If they're a chronic smoker, okay, same thing. They might have wetness in their lungs and all that stuff, which, just from being the bed bound and bedridden or having the chronic diseases and going from there. Things that you can find on the internet. Right. Systems-wise, all right. So cardiovascular, most common thing. What's the number one cause of death for these individuals? What? Most patients, geriatric. Heart failure, death, heart disease, and all that stuff. All right. So, of course, that's why this is the first one on the list, because it's the most common thing. All right. Just from the aspect of looking at our conduction system delays, that's why we have EKG changes and all that stuff. That's why they develop different arrhythmias and problems just because of heart damage and going from there. The blood vessels lose the ability to constrict and all that stuff. Or as we get older too, the notion of we start losing the collagen in our in the blood vessels and all that stuff. And that's why we start having abdominal aneurysms and dissections and all that stuff. All right. So all that goes into a factor. Affects changes ability and compensation for shock. And then, of course, heat and cold. All right. So how does shock differ from for these individuals? What is shock? Not all at once. Anybody get definition of shock for me?
You guys.
Body begins to decompensate, basically.
Okay. So what do we lose with shock? Okay. Our actual shock state is if someone's in shock. Take out the heat and cold explosion, all that stuff. So you get shot in the chest. Okay, you're losing blood.
Your blood volume.
Okay. So that's a blood volume. So it's a hypovolemic shock. Okay. What do we look for when someone's in shock? What's one of the signs and symptoms?
Skin color.
Skin color, blood pressure.
Blood pressure goes down, pulse goes up.
Okay, blood pressure goes down, heart rate goes up. Okay. That's all based upon the carotid body reflex and all that stuff. All right. So for the older patients, okay, in general, how do we compensate for shock? What does our body do? What is it trying to preserve? What organs is it trying to preserve? The core. Okay. So what does it do to the rest of the body? Shunts the blood back to the core and all that stuff. That's why we get the pale diaphoretic and all that stuff. Okay. So with these elderly geriatric patients, what can they not do? Looking at what's on the screen and all that. Okay. So they lose the peripheral resistance. They lose the ability of their blood vessels because they don't have all the elastic stuff to shunt blood back to the heart. Okay.
That's not about it.
Going from there. Guess you just have to take my word for that. Or you just don't care. I think you care. All right. Cardiac output, we know is a combination of heart rate times stroke volume. Stroke volume is a combination of preload, afterload, and contractility. How much blood, how much fluid we have in our body. Okay. So stroke volume is the amount of blood that's good squeezed out of the heart per beat. Okay. Our heart rate, on average, what's our average heart rate for an adult? 60 to 70. Okay. And we squeeze out between 60 to 70 mLs per beat. That gives us our 4 to 5 liters of blood per minute. That's how we develop cardiac output. Okay. So we lose our cardiac output. We lose our heart rate because of medications and all that stuff that they're on, and just from the aspect of heart disease that they problem. Okay. As we get older, our left ventricle gets bigger. Okay. When our left ventricle gets bigger, what do we start developing over time? Left ventricular hypertrophy leads to what? Potential. If the left side gets bigger and bigger over time, what happens? It says, I'm done. I give out. Okay. So you can have LV aneurysm, stuff like that, or they develop, just that's how you develop heart failure. Screw it, I'm done. I'm out of here. Okay, and of course coronary artery disease and all that stuff. Different syndromes and symptoms. Okay, angina pectoris, this is our chest pain, myocardial infarctions, death of the heart failure, dysrhythmias, dissections, aneurysms. Okay, hypertension and syncope. Syncope is passing up. 50% of individuals will have some form of high blood pressure once they get to age 65. Woohoo! Okay, and we know high blood pressure leads to everything else. Strokes, diabetes, kidney failure, all that stuff. Okay. Controlling it for us in the pre-hospital, one of the first medications that we use, of course, is nitro. Medics and all that stuff, they can give you the enalapril, captopril, beta blockers, and all that stuff. For us, unfortunately, as EMTs, not much that we can do. It's not in our scope of practice. Thank you and have a good day. What?
Come on.
High flow diesel.
Yeah. And then therapies. MIs, okay. Of course, the majority of these, okay, it's that silent MI, okay. Again, over age 65, what else? What are the problems do they have? They have the diabetes, okay.
Yeah, my mom had a silent MI.
And that's all right. So for females, when we get over 65, what's the most common symptom that they have?
Back pain.
Close? What?
Jaw pain.
Close. Both of those are there. Fatigue.
That's everybody.
Yep.
Like that's everybody. What are you talking about?
Yeah.
I'm about to fall asleep.
But again, yes, that's what you're saying is that's anybody, okay? But it's a very common thing that a lot of individuals that the elder, they'll come in and they're just more fatigued than normal, especially the females. That's usually one of the most common problems. And then they'll do the other complaints. The second actually most common from there is abdominal pain, and then with back pain and all that stuff.
Nausea.
Yep. So not just nausea, but vomiting. Yep.
Yeah, my mom she just got nausea and she had a silent MI in her sleep. She woke up nauseated, went back to sleep.
Yeah. So from the aspect of the most common, okay, not the classics, exertional pain when they exert, the vomiting, shortness of breath, and then chest pain that radiates to the right shoulder, not the left, to the right shoulder or to both shoulders, which is different from what other things. Other symptoms, weakness, fatigue, syncope, again, the passing out, confusions, and the TIAs and all that stuff. Okay. Heart failure, we know, as we're getting older, a lot of people have the CAD, they have the MI in their 40s and 50s, and then they deal with it because they're living into the 90s, hundreds and all that stuff. So we see a lot of this type problems. Right? For us, what's one of the first treatments for CHF?
CPAP.
CPAP? Okay. And then for medics and all that stuff, using Lasix is there, nitro, and all those captopils and all that stuff. All right. Prior to CPAP, if you don't have CPAP, what else do you want to do? What else can you give? Oxygen. Okay. Do we need to give high flow oxygen? How much oxygen do we give?
Not the main thing for 94.
Okay. Enough to give them above 94%. All right. Acute again, the end result, pulmonary edema. Okay. What's orthopnea? Shortness of breath with All right. So orthopnea is the shortness of breath when laying flat. Okay. So dyspnea, of course, is just a shortness of breath. Orthopnea is when you lay someone down, they become acutely short of breath. So these individuals with CHF, okay, what do? How do they take care of their orthopnea? Sit up, okay? Or, and it's, again, over time, they have the weight gain and all that stuff. So they have a little short of breath. What do they put behind their head? A pillow. And then a week later, they're still short of breath. What do? Another pillow. And then another pillow. And then they say, screw it, I'm going to go to the recliner. And then you find them in the recliner, and they're 4+ pitting edema and rails and all that stuff. Presentation, of course, like everything else, linked poor diet, medication problems. Okay. 4th of July, everyone has to have their hot dogs, burgers, and Diet Coke and salty chips and French fries and pork rinds.
Ooh, they still make those.
The spicy ones are good.
And of course, the aspect of MIs and going from there. We talked about treatment-wise, okay, CPAP, and then from there, for the medics, they can also use diltiazem, fib and flut for that sort of things. If we have access to end-tidal CO2, we should put end-tidal CO2 monitoring on them. Oregon boys and all that stuff.
We don't have it anymore. Yeah.
You lost the cable.
We lost them all.
Yeah, right.
Instead of just stealing them.
All right. Passing out syncope, okay, multiple causes. Okay. Someone over the age of 40 and they pass out, it is what? Painful is correct, yes. Falling down, smacking the face and breaking things, yes. Okay. But if you're passed out and you're over the age of 40, it is heart problem until proven otherwise. Okay. Now, if you're under 40, okay, what's the most common cause of people passing out under 40 in their 20s, teens and 20s? Neurocardiogenic syncope and or hypovolemia. So in your 20s, out drinking, drink too much, peed a lot, pass out, go from there. So the volume depletion, last one. Volume and shock, again, shock is just a hypoperfusion state, is what a definition of shock is. Okay, so our clinical signs and symptoms of shock: pale diaphoretic,
Heart rate's up.
tachycardic, hypertension. What's their mentation like? Confused. Okay. And again, a lot of this beta blockers can mask that. So they won't get their elevated blood pressure. Okay. They might not get the sugar that it needs. So it worsens the confusion and all that. Okay. And then from there, what we, again, consider normal blood pressure, quote unquote. Okay. Normal blood pressure is based upon males between the ages of 18 to 24 in the military. That's how they got the normal blood pressure. Okay. Right. So from that, an elderly patient, what is their normal blood pressure? Might be systolic. With or without, and that's of course always the question.
Normally high. So let's see.
Yeah, but that's again like what Todd's saying is everyone's different. So what we think as normal, they might be 110, 120, where they might be actually living to the 160s, 170s, 180s.
You know why you always ask them, what do you generally
What's normal?
run?
Yep. Okay.
By that age, they know.
Oh, it's probably not that.
For CHF, we do not need albuterol for CHF. Don't know how often I see that. Okay. So the second most common problem symptoms. Okay, so heart disease is number one cause of death and all that stuff. Second most common cause of death. What? What is the friend of the elderly? Disease-wise.
Oh, you're lucky you weren't there.
You really don't want to put that in this lecture.
Pneumonia. Pneumonia. So pneumonia. Pneumonia is the friend of the elderly. That's a lot of times what kills them. The heart disease drives them to the cliff, and then pneumonia kills them, pushes them off the cliff.
I thought it was your friend.
Okay. Or Viagra.
Oh,
That's some of their friends.
yeah, that, and then
New
the
friend.
That makes new friends.
All right. So on the respiratory side of it, of course, from the aspect of gag reflex, the problem, okay, we lose the ability to swallow, okay? So we can't swallow, thereby what happens? They aspirate. A lot of them develop, again, that leads to pneumonias and all that stuff. Bless you. Respiratory problems decreases and from there.
Oh, I'll be back.
Consequences of chest trauma. Okay, so these individuals that already have problems, then they go and break 4 or 5 ribs.
You can't breathe, so.
Then they can't breathe. Then they're having pain. Okay, and all that leads to the pneumonia and all that stuff. So pathophys, okay, they lose 7% of their PO2 levels. Okay, so they can't really do from that well with hypoxia or a lack of oxygen and all that stuff. We lose our minute ventilation or how fast we breathe. Again, there's calculations based upon all that stuff. A lot of them, they're smokers. So with the COPD and all that stuff, we have problems with CO2 retention. When we keep too much CO2, what happens to our body? Apollo 11, what was the whole concern with too much CO2? They get loopy, start having mental problems. Okay, they become confused. So your COPD patients, that's one of the problems with the concerns and all that stuff. They actually retain CO2, they become confused and go from there. All right? And then, of course, talk about the cough reflex. So short of breath, a whole bunch of different causes for that. Everything from pulmonary edema, asthma, CHF, bronchitis, blood clots. Okay?
I was going to say, is this to try to make us all feel like we got the elderly thing going on?
I'm not 40, but that's blurry.
It looks good on my screen. It's the projector. All right. So pneumonia is different causes of it. Bacteria is the most common for that. Okay. That's why they always say anyone over the age of 50 should have pneumonia shot. Okay. And then different viruses, herpes, that's one of the adenovirus, corona, and all that stuff. And then if you're down in the lower half of the Ohio, then you have to start thinking about fungus and tuberculosis and all that stuff. Ohio River Valley. Fungi. Again, for the aspect of being at risk, just being older, we can't clear our secretions. We don't have the immune system. Okay. A lot of these individuals are also on chronic steroids. They might be on other chronic medications that decreases their immune system, so they can't clear things. Or they're confined to beds and all that stuff. Right? Symptoms, which we know, okay? They may be normal tensive, or their temperature might be normal. Why do they complain of abdominal pain? They might complain of upper abdominal pain. Peeler.
increased effort in general, or?
Okay, it's one aspect. Yep, increased effort, trying to belly breathe, trying to get the air in. All right. So the nerves that innervate the diaphragm, okay, 4, 5, 6, are the same nerves that go to some of the other areas of the body. So that's where they get the referred pain. But the infection might sit on top of the diaphragm, and then again, the referred pain from the diaphragm to the abdomen. So they actually, a lot of times, they'll have upper abdominal pain, but it's really they're having a pneumonia. And then, of course, auscultation. Vaccination, okay. Trying to help encourage them to continue exercising, smoking cessation, the whole ounce of prevention and all that stuff. Exactly. If you're 100 years old, I'm not going to tell you to quit smoking.
At that point, are you willing to tell her not to have?
Ma'am, you're doing something right. Whatever you're doing, keep doing it. Just remember, COPD is a constellation of different diseases: emphysema, chronic bronchitis, and asthma. We're not going to really go much more than some of that. Hard to differentiate between, especially when we get to the 65, 70 years of age, and that's all based upon history. If they're an asthma patient their whole life, they'll at some point in time will develop COPD. Smoker their whole life, they're going to develop, your chronic bronchitis or your emphysema, depending on if they're a blue bloater versus a peak puffer. All right, and going from there. Of course, prevention, trying to get them to stop beforehand, making sure that they get their influenza, and encouraging them. I don't know if you guys do posters here or anything like that during flu season. Hey, might be a good thing for the casino to help out. And I would imagine they probably do a lot of hand sanitizing and with all the coughers and stuff like that. Other things for COPD, of course, short of breath, fatigue, decreased activity level. What's our traditional treatment for you guys? Oxygen as necessary. CPAP. How much PEEP do we start with our CPAP? Have you guys played with your CPAP masks recently? Do you guys have a CPAP mask here? Okay. Okay. Bronchodilators, albuterol, of course, is your main.
You start at the middle line or something.
Yeah, what's the middle line?
I don't remember the pressures.
Is it
Is it
5?
5 or
5.
5. So 5, 7.5, and 10.
That's like where you start though, to make sure.
Yeah. So 5, 7.5, 10.
Centimeters of water pressure?
Yep.
Is that what it is?
Centimeters of water pressure. Okay. CmH2Os. All right. So start at 5 and then titrate or dial it up based upon up to a max of 10. Now, if they're a CHF patient, how much PEEP do we start at?
7.5.
7.5, or actually go straight to 10. Okay. Got some guideline reviews, some guidelines to review. Asthma, of course, we know this is different ages and all that stuff. As we get older, we still have it. It's just one of the allergic, the different components is allergic versus something that's within our body. Management pretty much the same as everything else. Of course, sometimes the beta adrenergics, they can have problems. Okay, so when you're taking that albuterol, I've actually seen individuals that using the albuterol will go into an arrhythmia. Okay, based upon that medication. And this is the reason, the fear, the complaints why EMTs have to call for permission to give albuterol. Or one of. PEs, okay. These individuals are at risk for having blood clots. Why? Why is your elderly patients at risk for having blood clots?
The decreased output, blood stop moving.
Okay. So the blood's not circulating properly. Okay. What other diseases do these individuals might have?
Arteriosclerosis.
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 Okay. Cancer. You know that cancer causes an increase in viscosity, slows sludge and all that stuff. So immobility problems, vascular stasis, lower extremities, okay, all that's of course, and then other diseases associated with pulmonary embolisms. There's something called Virchow's triad, where it looks at venous stasis, injuries, okay? So they fall down, they break a hip. They have damage to the blood vessels, that puts them at a higher risk of having blood clots. And then the viscosity, things slow down. They have heart failure, okay? That's why a lot of these individuals on heart failure, except for the beta blocker, what other medications are they on? What? Aspirin, Coumadin, Plavix, okay? This is the reason why they're on those medications. If they didn't, they would develop blood clots and all that stuff. Of course, for us, pre-hospitalized, giving them oxygen, okay, if they're hypoxic, transport, okay, and then ALS, medications, fluids, and all that stuff if necessary. Nervous system, okay, we lose brain, okay, decreases, we lose blood flow to the brain and all that stuff, and our nerves start decreasing, okay. This is why a lot of the individuals, they have, the whole aspect, they might not feel things, or with the abdominal pains and stuff like that, because we just don't have the nerves that following it. We lose blood flows, we lose the number of brain cells, okay, up to half of our brain. Once we get into the 65 to 85 years of age and all that stuff. Of course, previous strokes, Alzheimer's disease, going from that. Okay. So a lot of things. Okay. Of course, don't always assume, okay, just because they're old doesn't mean that they have impaired cognition or, or they're confused as normal. Okay. Who do we ask if what's normal? What?
Either them, like family.
Start with them and then people that are around
Yeah,
them.
the people around them.
Okay. Which is appropriate. So different causes, dementia, infections, and all that stuff. I know you guys probably have not heard my ultimate mental status lecture, which we'll give at some point in time. Just as a reminder. You guys have.
Several times.
Several times.
A time or two.
So AIU tips, and we're not going to go through the whole thing. So just alcohol, acidosis, endocrine, insulin, opiates, uremia, trauma, infection, poisoning, psychiatric seizures. So just a quick, this is what we teach to the residents as a differential or way to go through what could this be. Okay, you're 65-year-old that's a chronic drinker. Okay, he has alcoholic cirrhosis. Okay, he has, stopped taking his lactulose. We have that reasons. And again, the aspect of infection, the eye. Okay, elderly patients, the most common cause for them for having altered mental status is infection, until proven otherwise. Other things though, okay, dizziness or the vertigo, all right, which we'll talk about in a little bit. TIAs, Alzheimer's disease, which is a growing thing. They actually say they might even have a vaccination or something for Alzheimer's or a cure, some point in time. And then seizures. All right. So what's the race score? Race score.
The stroke assessment.
Stroke assessment. Okay. So the RACE stands for Rapid Arterial Occlusion Evaluation Scale. Okay. Remember, it's based upon 9 pieces. Okay, going down, and it has a comparable to the NIH stroke scale. So I had to actually take a certification the other day, which was boring as all get up. Okay. And how to assess someone for the NIH stroke scale. Exactly. Yeah. It was not pleasure at all. All right. Just remember it's based on 9 points: face, arms, legs, head, and then either aphasia or agnosia. Okay. So depending on his left side weakness versus right side weakness. So face palsy and all that stuff go from there. So higher the prognosis, higher the score, worse the prognosis. Anything over a 5, if you look at the guidelines and all that stuff, a 5 should go to where? What type of hospital? Specifically, what type of stroke center? An interventional stroke center. Okay. St. Vincent's, Toledo, UTMC. Okay. If it's under 5, it doesn't matter. They can go to any stroke center. Yeah. So just by definitions, agnosia, asymagnosia, and anosmagnosia. Okay, agnosia is the inability of the brain to recognize. The asymagnosia is loss of recognition of or awareness, and the anosmagnosia is viewed as a deficit of self-awareness. Do I expect you to know that completely? Well, to a point. Okay, terms-wise and all that stuff, not. But it's important because when we get down, okay, at the bottom, all right. So point-wise, just as a reminder, okay, face palsy, okay, are they looking, okay, and with this is have them raise their eyebrows, have them smile, okay. Do they have a little bit deficit, no deficit, or a lot of deficit, okay. Arms up, holding a pizza, okay. Count to 10. And if they can keep it up there for 10 seconds with no drift at all, or they immediately drops down, or they can't lift it. Right? Leg, okay, up 30 degrees, hold for 5 seconds. So arms for 10, legs for 5. And then eye and head gaze deviation. Are they looking up? Okay. And one of the classic things that they say is if wherever their gaze is, that's where the lesion is. If they're looking up to the right, guess what? That's where the lesion is. That part of the brain. And then depending on the right side weakness, left side weakness. Okay. If the right side weakness, what part of the brain is affected? Left side. Okay. And what's on the left side of the brain that's important? Speech center. Okay. It's our speech and hearing centers on the left side of the brain. Okay. That's where you ask them. Okay. And just to reiterate, I hate this aspect because the score itself does not ask them to actually say something back to you. It's just, can they follow commands, which tests one part of the brain. Okay. So that's just the Wernicke Center versus the Broca's is the speech and all that stuff. All right. So I always have them say mama, dada, papa, huckleberry, no ifs, ands, or buts. It's blue sky over Toledo. We're rocking and rolling at the casino. What if you know? So I have them actually speech back to you and then take that into considerations. And then if their left side weakness, what side of the brain's affected? The right side. Okay. And remember, the right side is the artsy-fartsy side. Okay. Do we understand the whole premise of with the right side of the brain, they might not recognize that they actually have a left side of their body. That's where the asymagnosia and the anosmagnosia comes in. Okay. Whose arm is that? I don't know. Can you move your left arm? Nope, don't have one. Okay. They really don't understand that they even have a left side of their body. You can be stabbing it. Nope, not mine. Okay. There's truly a total of 11 points, but if they have both right side and left side deficit, guess what? It's a bad day. Okay. So technically it goes up to 9 points. Okay. And it is updated in the app. So you can, if you're having a stroke patient, if you need to review, go from there. Okay. Moving on. Vertigo, just illusion of motion, different causes, BPPV, ear infections, strokes, masses, and all that stuff. Something that's acute for the elderly patients, all that stuff. Usually a BPPV, benign positional vertigo, benign proximal positional vertigo, or they're having ear infections and all that stuff. Delirium. Okay, this is the wandering patient. It's acute onset. Okay, something causes them to have a altered, abrupt confusion and all that stuff. Okay, versus if it's not delirium, it is, what's the chronic confusion? What? Dementia. Okay, so that's the slow progress and all that stuff. So the chronic confusions and all that stuff. You like that, don't you? Just found that yesterday. Again, just from the aspect of dementia, differentiating, dementia versus delirium, acute versus chronic, versus, irreversible versus reversible. Okay. What's the most common cause of delirium? UTI, infection. Okay. And then going from there. Other things, of course, drug toxicities, metabolic changes, and all that stuff. All right. So most of these patients, most of the elderly patients, okay, what do they complain at nighttime? What can they not do? Sleep. Okay. So what do? They stay awake. Okay. Then they stay awake all night long, and then they sleep during the day. Okay. So they get a night-day reversal. That will cause them to have this. Or what's the other thing that they do? They want to get to sleep. What do they take? Sleep medicines. What's the most common sleep medicine that they take? Ambien's one of them. It's not actually. That's. Let me back up. What's the most common over-the-counter sleep medication? What? Melatonin's there. Yep. What else? Okay. What's the PM? It's the same thing as with Unisom and all that stuff. The PM is actually Benadryl. It's diphenhydramine. Okay. So they take a whole bunch of Benadryl. Yep. So they take the Tylenol PM. Then they're like going, oh yeah, someone told me to take some Benadryl to help me sleep. So then they take some more Benadryl. Oh, that's not working. So they take some more of this other medication that's a sleep aid, which also has the Benadryl in it. Okay. And then they actually develop an anticholinergic effect. They get red, confused, tachycardic, and all that stuff. All right. Alzheimer's, as we know, is just the most common cause of dementia. Okay, majority of cases over the age 75 and all that stuff. Don't know the exact causes, but we're starting to figure out maybe some plaques in the brain and all that stuff. All right, first time seizures in the elderly is bad. Okay. And like what we talked about earlier from the aspect of with the low blood sugar causing seizures and all that stuff. Electrolyte imbalances, okay. Our chronic alcoholics, you run over to 17th Street, 107 17th Street. But, we know that. Infections and going from there. GI, again, taste. We lose ability to taste, we lose mobility, okay. They lose their teeth, they have to gum stuff. Dentures don't always fit properly and all that stuff. Okay. And then at the bottom, with the reflux and heartburn and all that, going from there. Peristalsis, we lose that. A lot of these individuals had previous bowel surgery of some sort, hernias, those sort of things as we get older. Absorption tracts, problems, peristalsis, and again, they lose their taste, they lose their smell, they lose their nutrition. When we lose our wants to eat and all that stuff, what happens to our body? Shuts down all that stuff. Okay, so bowel obstructions, different causes. Different things from the aspect of, stool impactions, volvulus, adhesions, and all that stuff as the causes. Biliary disease. So someone complaining of right upper abdominal pain. Okay. Biliary and all that stuff. cholecystitis, hepatitis, and then those are the signs and symptoms, all that stuff. Charcot's triad versus Reynolds pentad and all that stuff. Again, things they not to go. Peptic ulcer disease, all right? So a lot of these patients, they're taking pain medication. Okay, what's the most common pain medicine that they take all the time? What? Ibuprofen. Okay. On Jeopardy at 7:30, who always sponsors Jeopardy? Aleve. Yeah. So 7:30, who's watching television at 7:30? Old people. And Aleve is the one. Tell me that's not good marketing.
That's good.
Okay. And so from there, we know that Aleve, again, common thing. H. pylori, again, it's another one. Stress, steroids, and going from there.
So I know with the heart meds my dad takes, he's not allowed to take Aleve
Well, with the Coumadin too.
Yeah.
because it interacts with him.
Yeah, Coumadin.
So-
Some
Coumadin and stuff like
So
that,
is
they
it,
can't take
is it Aleve that
anti-inflammatories.
sponsors them or is it Advil?
Aleve
There's a lot of
sponsors.
them.
Yeah.
I don't know, I don't watch it, so.
Yeah, Aleve sponsors. I watch it all the time. Trust me.
Before you go to bed at 9.
Yep.
8 o'clock.
Actually,
8
I'm
o'clock he goes to bed.
put the kids down at 8. I go to bed at 8:30 because I'm up at 5. All right, GI bleeds again from the aspect that we know a lot of these individuals on Coumadin, Plavix, Xareltos. Now they have a whole bunch of even newer medications and all that stuff, Effeans and stuff like that. Different causes, kind of sort of what it looks like. They're doing an EGD, just everything's eroded and go from there. Diverticulitis, cirrhosis, bowel obstructions. Right. So upper GI hemorrhage. A lot of the elderly patients, again, from the aspect of they're taking the different medications, everything's slowing down, and go from there. So if it's an upper GI bleed, okay, what's the most common signs and symptoms? Black tarry stool, okay, or cough, ground emesis, and all that stuff, okay. If it's from the esophagus, what is it?
Like, well,
Yep, vomit, red, and all that stuff. All right. So depending on if it's a varices, alcohol abuse, and all that stuff, they can be throwing up blood, and all that stuff. But yeah, then from there, if it's on the stomach, the darker red cough, ground emesis, and the black tarry stools. All right. Lower GI bleeds, different causes, diverticulitis, cancer. Okay. Most painless rectal bleeding is cancer until proven otherwise in this age population. Right. Signs and symptoms, what does it look like? Red, okay. But don't forget about the other signs and symptoms, okay? They might be dizzy, why are they agitated? Why are they agitated? What? Hearts, what else? It's on the board. Okay. So they're dropping their blood pressure. When they drop their blood pressure, they're now becoming they're becoming shocky. When we drop our blood pressure, become shocked, then we start having mental status changes and all that stuff. And agitation. Okay. Also remember too, they're hypoxic. Okay. So they're not circulating, they don't have enough blood circulating around to carry oxygen. Okay. So for you guys, treatment includes what? Oxygen. Okay. Getting them to the hospital.
Burrito.
Burrito style. Life Squad 2, Life Squad 8, depending on where we are. You might get Life Squad 1 over here. Okay, and then all the other signs and symptoms going from there. Okay. Bleeding, of course, lower bleeding, different risk bleeding, hematemesis versus melanoma, all that stuff. Okay. We do know renal function decreases as we get older. Okay. A lot of these individuals, again, depending on medications that they're taking, ibuprofen, of course, is a huge factor. Going down, they get hip pain. They take a whole bunch of ibuprofen, take a whole bunch of ibuprofen, and it kills their kidneys. Okay. At the same time, they're puking up blood and going from there. They get sick, into the hospital, they get an infection, they're in the hospital for the infection, they develop sepsis, their blood pressure drops, it kills their kidneys, they go on dialysis. They go on dialysis, now they're 85 years old, what do they not want to do anymore? They only got dialysis, then they die and all that stuff. All right? So, all right. So for the aspect too is, okay, when our kidneys start shutting down, a lot of these medications are renally excreted. Okay, so if our kidneys aren't working, we can't excrete it. We have a buildup in some of the medications, and then they become confused and altered and all that stuff. Everything kind of sort of plays together. Of course, as we get older, most of us have to have male-wise some form of, we have to have a TERP or something. Okay, the transurethral prostatectomy. Okay, prostate gets too big. Can't pee, have bladder backup, fluid backup, kills the kidneys, go from there. Colorectal cancer, of course, can come across. Diverticulitis has a problem and can irritate the bladder and bowels and all that stuff. Okay? Again, after 50, okay, risk increases for men, most common in females just because of the short urethra and all that stuff. Most common cause of infection. Other things, of course, take into consideration, diabetes, obstruction, and all that stuff. For those that have the unfortunate of the indwelling catheters, or even for those, you might have a lot of them, the suprapubic catheters, okay, because they have problems with bladder. They might have had, females from the aspect of, they might have had cancer with radiation and all that stuff, so it destroys, damages, and goes from there. Incontinence. Okay. We know that a lot of the individuals, okay. Yeah. We know a lot of the individuals that we get, they're bedbound, they're bedridden, okay. They have the diapers on, okay. Have the problem with the continence. What happens with that? Skin irritations and go from there. It's not fun to get old, is it?
Oh yeah. I've never been this age before. No.
Fascinating.
So again, as we age, our bladder decreases. We can't hold as much. Is another reason why we have to run to the bathroom 3, 4, 5 times a night. Okay.
I'm like, damn.
And then from there, as we're running to the bathroom and we trip and fall, what happens?
You break
You
your
break
hip.
your
You
hip.
break your hip.
Throw a clot, and then we die. Thanks.
Dip all the clot, exactly.
All at once.
It all comes
There
together.
you go.
Okay.
Look at these young guys over there. What ain't gonna happen to me?
I still got about 20, 30 years.
So remember, from the aspect of being non-judgmental, cover the patient's clothing, try to, if you can, cleaning them up, possibly helping out and going from there. Urinary retention, exact opposite, different causes, okay? Bladder infections, they just had their catheter removed, now they can't pee. That's a very common thing that we see all the time and all that stuff. We also have the aspect of, the pain, radiation of pain and developing acute versus chronic renal failure. So skin, 20%. Dermis thins, okay. Some of these individuals are on chronic steroids. Okay? Chronic steroid use and all that stuff also causes thinning of the skin too. And then easily bruising and all that stuff. Some of the other medications. What?
Thank God I'm gonna stop sweating.
Yeah. Yeah. Again, from the aspect of thermal regulation, they become easier dehydration, more easily dehydrated, and all that stuff. Some of the other medications, Coumadin, can have problems and all that stuff too. Affect healing, wound, all that stuff. Right? So just from the aspect of considerations, be gentle. Okay, if you have to use ECG and if you help them put on EKGs and all that stuff, being nice, putting it on, or when you're taking them off, Okay,
Yeah, I ain't doing it.
I've had patients, just simply taking off EKG leads and all that stuff tear skins. Okay, paper thin skins and all that stuff.
Band-Aid off and go, not even know
Yeah.
if it's DP one.
Oops.
I really do.
So cellulitis, most common cause is bacterial infection, that being staph, which is on all of us. Okay, lower extremities. Why the lower extremities? What? Okay, so they have peripheral vascular disease. Okay, and a lot of them diabetes and all that stuff. So they have
Sugars.
Just the sugar.
just the sugar.
He's stuck in the sugars this month.
It is the sugar. Pressure ulcers. Okay, most common locations for the pressure ulcers. Buttocks.
Elbows.
Shoulders, isn't
Yeah, I've seen someone.
Shoulders
it?
and yep, then the heels.
Oh,
Yeah, heels are big.
Yeah.
Okay, yep. Don't forget the heels. Okay. And again, the unfortunate, it's all lack of tissue, oxygen, and all that stuff. Okay. That's why they should, for the elderly patients that are bedridden, truly, it should be changed, moved every couple hours, so that they don't develop. Back, shoulder, spine, of course, talked about, rim of ears, going from there. So it's going to be a stage 2-3 ulcer. Okay. Herpes. Okay. Another thing, so that's why they should get, they should get the shingles vaccinations and all that stuff. Okay. Shingles, all it is just the varicella virus, the chickenpox virus. That's what causes. Okay. It's already in us, can't go away. Depending on where it can affect the aspect on the face, like that, can take pictures of problems with the eye, so they can have that. Or they can have what's called Hamsey runt, where they actually have damage to the ears or the shingles in the ears and all that stuff. This is Hutchinson's sign, where you have the tip, a little bit of the shingles on the tip of the nose and all that stuff.
I don't report to that.
All right.
Pain medication, antiviral medications, and then that's much more for us in the pre-hospital. Musculoskeletal. Again, as we get older, females more than males. Okay. This is the one exactly. This is the one time that it's actually. Yeah. Everything else, males are the weaker sex.
Extremely.
I just might break a hip before you do.
Yeah.
I'll break the hip train out.
We lose muscles, we lose joint flexibility and all that stuff. Our discs, the vertebrae start shortening down because we lose height. And they actually say that we can, 1 to 2 inches of height.
Exactly.
What?
It's only 1 to 2 inches?
Potential.
I'm about to show you a picture after this.
Yeah.
I heard this call before, never here.
More common, postmenopausal women, all that stuff, bone loss. That's why they say that if you're actually not building up your stores right now when you're young, okay, you're going to have problems and all that stuff. In this area, this time period and all that stuff, make sure that you get your lot of vitamin D, making sure that you're taking your vitamin D, during the winter time because we don't get enough vitamin D. 2-3 inches compression vertebrae, postural changes and all that stuff. Osteoarthritis, okay, degenerative arthritis, just hip pains and all that stuff. Hips, shoulders are the most common. A lot of people get knees. Of course, the elderly that are more the obese elderly too, they'll get the knock knee, the genivalgum. And then from there, that causes the whole changes of their body mechanics, and that's a lot of times they'll get the knee pains and hip pains and all that stuff. Of course, fractures. They trip and fall. They break a hip. A lot of times they try to protect themselves. They put their arms out in front. Okay, break a ulnar and radius, or they break both of them. Things that we do, simple things and all that. So femur fractures, it depends on where it is. Is a neck? Is it through the intratrochanteric? So it goes between the lesser trochanter versus the greater trochanter. The most common is through the femoral neck and all that stuff, and there's different pieces of that. So for falls, even when we're going out and assessing patients for other reasons, our lift assists, okay? Take that into consideration and do a quick examination of the house and see if there's risk factors at the house, okay, for them to make them fall. Do they have rugs? Do they have well-lighted, conditions? Do they have problems going upstairs and all that stuff? Try to prevent it, okay? Falls is, again, one of the leading causes of death because they break a hip, then they throw a clot, they get pneumonia, then they die. Okay. So, laundry list of things that you can go through looking at armrests, chairs, handrails, things that we can do to help be preventative. Metabolic endocrine. All right. So different things from the aspect of, thyroid disease, diabetes. Okay. Yes, there's still, some elderly, females and all those stuff are still doing hormone replacement therapies. They don't want to go into menopause yet. Okay. But that does put them at risk for breast cancer and strokes and all that stuff. Again, from the aspect, and we're not going to talk about all of these, but Graves, Addison's, Cushing's disease, so that leads to osteoporosis and then the diabetes. Okay. Diabetes, okay, most common cause or form for them is type 2. Type 2 is not insulin, okay? So they are insulin resistant, okay? And then they're not quite making enough of it, okay? Or it's not working properly. And that's why some of the different medications. We do know that aging has the problems, family history and all that stuff, foods that we eat and drink, okay? They're actually saying now that, a lot of the diet drinks are not good because of this. But yeah, I still drink it. Go figure. Of course, hypoglycemic. Okay, confused. Okay. They might not always have the warning signs, or they might not recognize the warning signs. They're on the beta blockers. They don't get the agitation. They don't get the elevated heart rate, the diaphoresis, and all that stuff. So they just don't know, and they just pass out. It doesn't fall out. What? DFO? DFO. Little old lady fall down, go boom. Different signs and symptoms for hypoglycemia versus hypoglycemia, which we kind of sort of know all that stuff. Okay, so HHNK, okay, or honk. Okay, this is something more common in the aging population. Okay, so this is the diabetic ketoacidosis, quote unquote, of the elderly. Okay, except they don't develop the ketosis. So they have the high sugars. They have what's the osmosals, okay? So they have that high, and a lot of they're dehydrated, okay? So for you guys, it's just more of notification and education. Check the blood sugar. Your blood sugar may actually read greater than 700 or greater than 600, depending on your monitor and all that stuff. Hi. Okay.
Says you're high.
Yeah. Signs and symptoms, again, similar to diabetic ketoacidosis and all that stuff. Confused, alter, the complaining of thirst. They want to drink and drink and drink and drink and drink. Environmental side, okay, different factors that play into effect, like everything else, the heat and the cold, like what we talked about, everything, all the signs and symptoms, lung problems, heart problems, alcohol use, as a lot of them do. They smoke, they drink, they go from there. Medications, all that will factor into the environmental side. Okay? Hypothermia, environmental cause of death and all that stuff. And again, for the elderly and the heat disease and this time of the year, one or two usually die from heat-related injuries and all that stuff. Like everything else, okay, if taking the high considerations of suspicion, really hot, really cold, do they have those problems? Again, from the aspect of we lose in the hypothalamus, it doesn't work properly inside the brain, so we don't have the ability to regulate the temperature. We can't get the temperature out of our body because our heart isn't working properly. We can't sweat as well. Okay, so we lose the perspiration side, okay, the whole vascular resistance or vascular side of things. Changing gears a little bit, and then on the home stretch. Psychologics, depressions and all that stuff. All right, pretty much go down the aspect of the depression. But we do have, as we do get older, a lot of them, they do get the paranoids, again, from the aspect of with the dementia and the delirium and all that stuff. So they'll start getting paranoid. One of my old neighbors would come up to me all the time and say that someone was stealing her bed climbing into her house and stealing her bed and stuff and going from there. So police was over to her house quite a bit.
They want her bed.
Yeah. Depression, we know, okay, as we get older, just the loss of family, friends, the fear of dying ourselves and all that stuff, the aging population problem and all that stuff. All right. Over the 85, 20% suicide rate. Males are 3 times greater than females. Okay. White, 15%. Black, 6. Hispanic, 7. Okay. And a lot of it is, again, other signs and symptoms, chronic diseases, and going from that. So if you're male over the age of 85 and you're white, guess what?
What do you got that there for, Mark?
Okay, Mark. Start planning it now.
No planning, please.
Wow.
Okay.
She is pushing you into the coffin, not even on the door, into
Well,
the
she's
coffin.
throwing.
18% of all suicides are committed by elderly. Okay. Again, over the age of 65. 1/5. And a very, small numbers and all that stuff. Okay. So we do need to take into consideration, so when the elderly patients are talking, or, hearing and seeing, or if you have family members that are over 65 and they just, the whispers, because a lot of times they don't actually say anything, okay, because they go undiagnosed and all that stuff. Right. And then they just went out disproportionately high and all that stuff. Of course, males a lot of times they do stupid things, run out front of traffic, shoot themselves, jump off bridges. Females, there's more pills and all that stuff.
Those are Pokemon.
But yeah, just Pokemon.
Watch for that break. Exactly. Watch for that break, Mark.
Oh yeah, because the family won't say it was suicide, so they were playing Pokemon.
Yeah.
That's it. We're at Nintendo, we want a Kevorkian.
This has just gone downhill with Pokemon. Go. All right. Getting back to substance abuse so we can finish this up. Okay. Again, as we get older, we lose employment, we retire, we lose our spouse, from the aspect, some of them do become, addicted to narcotics and stuff like that because they're tired of being in pain from their hips, their shoulders, and all that stuff. Again, from this age population, a lot of them are already previously using, different drugs and all that stuff, and then going from there. Alcohol is a very prevalent, aspect just from the loneliness and going from there. Okay, declining health.
Ridiculous.
Okay, 1/3 will develop some form of alcohol-related, problems after the age 65. Again, like everything else, okay, you know, well hidden, all that stuff. We had patients, they come in, then they were already intoxicated, and oh yeah, they had the liquor bottle between their legs, and throughout their stay in the hospital, they're taking some swigs and all that stuff, and continue to remain inebriated.
Hey, the best one I see, the doctor issue a beer a day to a patient I've had.
Yeah, I used to do that all the
I
time.
was like, I want your doctor.
Yeah. Because you're not, in the hospital, a lot of times you're not going to stop the patient from drinking, but it's the best way to prevent the DTs and all that stuff. Yeah, that are putting them on an ethanol
That
drip.
made his day. He just looked forward to it every day.
Yep. Other concerns, of course, just remember from the aspect of metabolism, liver's not working well, so we have problems with, having drug metabolism. We can't get rid of it because of kidney, failure, a lot of the drugs we lose as we get older. We lose muscle mass, but we gain fat and all that stuff. So a lot of medications are stored and go from there. Eye changes, short-term memories. Ooh, did I take my medication? Oh, I didn't take my medication today. Oh, I better take my medication again. Oops, I didn't take my medication for 4 days, so I'm just going to take all my medication at one time. Yeah. And then, of course, you have the whole concern for, polypharmacy and all that stuff. Okay.
Yeah, I think he lives on Lilas.
So just remember again from the aspect, unfortunately, a lot of patients, they have multiple doctors. This doctor does not do this doctor, this, but a lot of that's changing with the advent of electronic medical records and all that stuff. So we can kind of at least talk, and then pharmacists are becoming a lot more proactive in helping out, taking care of that problem. Okay. Of course, 30% increased geriatric hospitalization just based upon medications. Okay, screwing up or not taking it and going from there. Of course, we do have medication non-compliance. Okay, they're on a limited budget. Okay, they're on Social Security. They can't afford the medications. Ooh, am I going to eat this week, or do I need to, pay for this $5,000 bill, medication bill and all that stuff? So there's a lot of other reasons and all that stuff. And of course, sometimes they don't understand the medications, why they're taking the medications. Why do I need to take this medication that then affects this medication that affects this medication? Oh, and I can't eat beforehand for this medication and all that. And then the whole aspect of, pill bottles and being able to open their pills and go from there. Okay. So elder abuse. Yeah, no.
Send me signs.
Okay. There's no real from the aspect of socioeconomic bounds. Okay. The rich are affected just like the young and all that stuff. A lot of them are abused in their own homes. Children that are coming to take care of them now, just because one reason or another and all that stuff. Similar to child abuse, okay? They can have emotional, could be psychological and all that stuff, neglect, just from the whole aspect of, ooh, I don't want my, mom to die or anything like that, but then they don't do anything to help take care of the problem and go from there. We do know advanced age, mid-80s, a lot of problems with that, lack of dependence, or they're completely, lack of independence, completely dependent on family members to do, change, everything, feed, and then the whole aspect of nocturnal wandering, their day-night sleep switches and all that stuff. Like everything else with child abuse, taking into consideration histories and the stories. Okay, something just doesn't look right. Okay, what are we supposed to do? We are actually required by law. If you suspect it, we are required by law to contact CSB. Okay?
Oh, you? Yeah.
So the whole aspect of, well, I told the emergency room, nope, that doesn't count for them. Okay? So we have to call. Because they're hoping that if we get enough individuals, someone will actually make the referral and go from there. All right, finishing up, okay? Geriatric traumas. Again, we talked about a little bit of this in the past and all that stuff going down, just from the aspect of reaction times and, hearing, vision loss, the victims of crime, the, gentleman several years ago that was, shot, he was minding his own business in his car and actually was truly minding his own business. Okay. Less favorable outcomes for them. Again, like everything else, their body can't compensate properly. Their blood pressure drops. They have problems. They go into renal failure easier, pneumonias, rib fractures, and all that stuff. Like everything else, related to previous problems and diseases and all that stuff. Okay. If we have, for recovery, if we have a decrease in renal activity, problems with, again, going into shock and all that stuff, or the respiratory problems, they get intubated, the likelihood of surviving is almost dismal. So for the head injuries, of course, take into consideration, they could have fallen down a month and a half ago and don't remember it, and then they start having confusion and all that stuff. And we scan their head and they have a subdural hematoma, stuff like that. Brain shrinks, more wiggle room, or their brain shrinks, more wiggle room, and they're an alcoholic. All that takes into considerations. Hematomas, intracranial pressures, consciousness in them. Okay, so cervical fractures, again, going from the aspect of their osteoporotic. Okay, the unfortunate sometimes they're walking, they trip, they fall, they smack their forehead. Okay. They're not complaining of anything, but then they can't move their upper arms. Okay, you can actually, have a C2 fracture, which is called a central cord injury, where they can walk and move their lower body, but they're walking around and they can't do anything with their arms. Yep. If you do have to backboard them, okay, if you quote unquote have to, okay, take into consideration padding and all that stuff, putting stuffed towels, lifting the head up if they're a little kyphotic, to give them some space and all that stuff. They do make basically it's this little backboard pad thing that you can blow up to it cushions on the right spots. That's only if you have to. Chest traumas, like everything else, brittle ribs, stiffening lungs, they might have the COPD, from the aspect of if they get intubated, positive pressure, makes them at high risk of having pneumos, and then the low, problem with the hyperperfusion, with hypoxia and all that stuff. Cardiovascular, like we talked before, they don't have the volume, they're on a lot of the medications. Blood pressure drops, and it leads to the other problems too. So they can actually develop an MI and strokes and all that stuff. Just remember the whole aspect of what's normotensive for them and blood pressure medications. Burns, they don't do well with burn, both from the aspect of the treatments that we give them, and then also from the ability to heal themselves. They're at high risk for infections and all that stuff. We talked about the kidney problems with the burns. Orthopedics, we talked about that already. Hip fractures, positioning, packaging, and going from there.